I would try to finish it, try to summarize it briefly and in a simple way as far as possible. So, Dr. Pankaj sir, can we start now?
You can start, sir.
Okay. Okay. When we talk about epilepsy management, the first thing to decide is whether a particular patient needs treatment, needs anti-epileptic drugs or not. So the first question is when to start anti-epileptic treatment or anti-epileptic drugs. Not every patient who has a seizure would require treatment with anti-epileptic drugs. And the first thing to consider whether the patient requires AED or not is to decide whether the seizure was a provoked seizure or an unprovoked seizure. A provoked seizure is one which is caused as a direct result of either brain insult or a systemic insult. Brain insult, the examples of brain insult would be acute stroke, head trauma, or encephalitis, while the examples of systemic insult would be, for example, drug intoxication or drug withdrawal like alcohol withdrawal, or metabolic derangements like hyponatremia. On the other hand, unprovoked seizure is a seizure which is caused either without any reason. In that case, it is called as idiopathic seizure, or caused uh, with a pre-existing brain lesion, or during an ongoing neurological illness. In that case, it is also known as remote symptomatic seizure. So we have two types of unprovoked seizure: idiopathic seizures and remote symptomatic seizures. If a patient presents with a single unprovoked seizure, then we do not need to start treatment. Uh, However, certain risk factors increase the risk of recurrence even after a single unprovoked seizure. If those risk factors are present, then we should start treatment even after a single unprovoked seizure. These risk factors are epileptiform abnormalities on EEG. If a patient presents with a single unprovoked seizure and EEG shows epileptiform abnormalities, then we should start anti-epileptic treatment. If a remote symptomatic cause is identified either on history or on neuroimaging, for example, there is history of significant head trauma in the past, or if there is history of meningitis or encephalitis in the past, that would make as a remote symptomatic cause. Also, if MRI or CT scan shows an area of gliosis, that would also make it a remote symptomatic cause. In that case, also we should start treatment after a single unprovoked seizure. If there is abnormal neurological examination, either in the form of focal neurological deficits or intellectual disabilities, then also the risk of recurrence increases. Or if the seizure was a nocturnal one, then also the risk increases. Apart from these risk factors, there are also three minor risk factors which also increase the risk. These include first presentation with status epilepticus, a past history of febrile seizures, and a family history of seizures. If any one of these risk factors are present or is present, then we should start AED even after a single unprovoked seizure. If none of these risk factors are present, then we should not start AED after a single unprovoked seizure. However, if the patient has a second unprovoked seizure, then we have to start AED in any case. On the other hand, provoked seizures do not increase the risk of long-term epilepsy. So long-term anti-epileptic treatment is not required after a provoked seizure. So once we have decided that we need to start anti-epileptic treatment, the next question arises, which drug to start? We have more than 20 AEDs available now. So how to decide which AED to start in a particular patient? We have to take into consideration various factors which we can classify or which we can divide in three categories: drug related factors, seizure related factors, and comorbid medical conditions, which would help us in deciding which AED to choose in a particular patient. We'll discuss these factors in slight detail one by one. Now coming first to drug-related factors. Obviously, the first parameter is the efficacy of the drug or the comparative efficacy of various drugs. There have been a limited number of studies which have compared different AEDs head to head as initial monotherapies, and most of them have shown that these drugs are mostly equally efficacious. However, the largest trial, double-blinded control trial, the SANET trial, the standard and new anti-epileptic drug trial, which was published in 2007, concluded that for focal seizures, lamotrigine should be considered as a drug of choice, whereas for generalized seizures, valproate should be considered the drug of choice. And recently, findings of SANET 2 trials were published, in which they concluded that for generalized seizures, valproate is superior than levetiracetam. We nowadays we use levetiracetam left, right, and center, but the SANET 2 trial concluded that for generalized seizures, at least, valproate is superior than levetiracetam. Now, coming to pharmacokinetics can also help in deciding which drug to choose. Many of these drugs can be used as twice daily dosing. However, some of these drugs can also be used as once daily dosing. Once daily dosing improves compliance of the patients, and which can improve seizure control. The drugs which can be used as once daily dosing include extended release phenytoin, extended release divalproate, extended release lamotrigine and levetiracetam. Also, carbazepine has a longer half-life, so it can be used as single daily dose. Phenobarbital, perampanel, and zonisamide has pretty long half-life to the tune of around 100 hours, so they can obviously be used as single daily dose. The advantage with drugs like perampanel and zonisamide is that even if we miss one dose, that should not affect the efficacy of the drug, and should not cause a recurrence of seizure or breakthrough seizure even if we miss one drug, which can happen with drugs with shorter half-life like carbamazepine. Some drugs induce the hepatic enzymes, so which can increase the metabolism of other drugs which are metabolized through liver. For example, these drugs include phenytoin, phenobarbital, carbamazepine, and oxcarbazepine. So these drugs can render ineffective other drugs which are metabolized through the hepatic enzymes. So as far as possible, we should avoid drugs which have hepatic enzyme induction as their property. On the other hand, some drugs inhibits the hepatic enzymes, which can lead to accumulation and toxicity of the drugs which are hepatically metabolized. Examples of this mechanism include valproate. Although the hepatic enzyme inhibition is not as prominent as hepatic enzyme induction by phenytoin and carbamazepine. Some drugs like levetiracetam and zonisamide has no interaction, so we should prefer these drugs whenever we are using AED in a patient who is using multiple other drugs, so that there is less chances of drug-to-drug interactions. Side effect profile can also help us in deciding which drug to give in a particular patient. Some drugs can cause significant neurocognitive dysfunction, or like phenobarbital and topiramate. We would like to avoid these drugs in patients who are already neurocognitively impaired. Some drugs can cause hypersensitive reactions like drug rash, which can sometimes lead to Stevens-Johnson syndrome or toxic epidermal necrolysis. Lamotrigine is most notorious in this regard. However, this effect can be reduced if we start lamotrigine at a very low dose and increase it gradually. That is why lamotrigine is started at a very low dose and it is built up very gradually, and this makes it a poor choice if we want to have rapid anti-epileptic effects. Carbamazepine and to a lesser extent oxcarbazepine and phenytoin can cause drug rash and Stevens-Johnson syndrome more prominently or more likely in patients who have HLA 1502 allele. and this allele is more common in patients of Southeast Asian ancestry. For this reason, US FDA has recommended that whenever we start carbamazepine and probably also oxcarbazepine and phenytoin in patients of Southeast Asian ancestry, we should check HLA 1502 allele first before starting these drugs. Some drugs like valproate and carbamazepine can cause weight gain, while other drugs like zonisamide and topiramate can cause weight loss. Although these side effects can be utilized for the advantage of patients. For example, in a patient who is thin build, we can use valproate and carbamazepine, and in a patient who is obese, we can use zonisamide and topiramate. Cost is also a deciding factor, especially in a developing country like India. Now, coming to seizure related factors, the most important factor which decides which AED to use is the type of seizure, focal versus generalized seizures. Some drugs are broad spectrum, that means they are effective both against focal seizures as well as generalized seizures. Examples include valproate, levetiracetam, and now brivaracetam, lamotrigine, topiramate, and zonisamide. Some drugs are narrow spectrum. They are effective only against focal seizures, and they're not effective in generalized seizures. Examples include carbamazepine, oxcarbazepine, eslicarbazepine, phenytoin, phenobarbital, and lacosamide. So we should know before starting AED which type of seizure we are dealing with. We should also take into consideration the specific etiology of epilepsy. Okay. Before specific etiology, this table shows that some anti-epileptic drugs can potentially worsen some type of generalized seizures. For example, generalized onset tonic-clonic seizures in both adults and children can be precipitated or aggravated by carbamazepine and phenytoin, while absent seizures in children can be precipitated by carbamazepine, oxcarbazepine, phenobarbital, and phenytoin. In patients of juvenile myoclonic epilepsy, absent seizures, myoclonic seizures, and sometimes GTCs also can be precipitated by carbamazepine, phenytoin, oxcarbazepine, and interestingly, lamotrigine can precipitate myoclonic seizures in patients of JME. Lamotrigine is one of the drugs of choice for JME, especially in female patients of childbearing age group, because in these patients we cannot use sodium valproate, and lamotrigine can precipitate myoclonus also in these patients. Now, coming to specific etiologies, if we are using AEDs for post-stroke epilepsy, we should use drugs which have less drug-to-drug interactions, because these patients are using several other drugs also, like antiplatelets, statins, and most of the time some drugs for hypertension and diabetes. Similarly, if you're using AED for brain tumor, we should use drugs which have less interaction, because these patients often use chemotherapeutic agents. Now, coming to comorbid medical conditions, sometimes comorbid medical conditions help us in deciding which AED to use. For example, if a patient has a significant renal disease, would like to avoid drugs which are renally metabolized, like levetiracetam, topiramate, zonisamide, or lacosamide. Similarly, in patients with liver disease, we would like to avoid valproate, phenytoin, and carbamazepine. Psychiatric comorbidities can also help us in deciding particular AED. For example, valproate and lamotrigine are mood stabilizers. So if a patient also has mood disorder along with epilepsy, would like to use valproate or lamotrigine. On the other hand, we should avoid phenobarbital and topiramate in patients with depression, because these drugs can exacerbate depression, and we should definitely avoid levetiracetam and perimpanel in patients with psychosis, because these drugs are known to cause psychosis. Similarly, valproate and topiramate are effective in migraine. So if a patient has migraine and epilepsy, we should choose either of these two drugs because these can valproate or topiramate can treat both epilepsy and migraine. If a patient has risk factors for osteoporosis, we should avoid phenytoin, carbamazepine, phenobarbital, and valproate because they can increase osteoporosis. So these, considering these factors, we can decide which AED to choose in a particular patient. Now, an important issue is how and when to discontinue AED. If a patient has remained seizure free for 2 to 4 years, probably it is the right time to begin a discussion with the patient regarding whether to continue or whether to stop AED. Both have continuing or discontinuing has its risk and benefits. The benefit of discontinuing drug is that it gives a sense of being cured to the patient. It eliminates the possibility of adverse effects, and also it eliminates the cost associated with treatment. However, the risk is obviously it involves risk of recurrence of seizure. There are certain risk factors. If they are associated, they increase the risk of recurrence. These factors are uh, epilepsy duration. Longer the epilepsy duration before remission, more are the chances of recurrence. A shorter seizure free interval before remission. uh, Age, seizure recurrence is more likely in adult patients as compared to children. If there is history of febrile seizures, if patient had more than 10 seizures before remission, if there is no self-limiting epilepsy syndrome, if EEG shows epileptiform abnormalities, if there is identifiable brain disease, intellectual impairment, abnormal neurological examination, multiple seizure types, poor initial response to AEDs, if the patient was on combination therapy, if there is family history of epilepsy, or if MRI shows hippocampal atrophy, all these risk factors increase the chances of recurrence. We should remember that even if none of these risk factors are present, then also the risk of recurrence after stopping AED after a seizure-free interval of 2 to 4 years is not less than 20 to 25%. It's not a small risk, and with each of these risk factors, this risk of recurrence increases 1.3 to 1.5 times. And the important thing is that two-thirds of these recurrences occur within the first year of stopping the drug. So the decision to stop AED should be individualized in each patient and should be made after a thorough discussion of risk and benefits with the patient. An important issue is management of epilepsy during pregnancy. It can be discussed under three headings: preconception, during pregnancy, and postpartum. Pregnancy in every woman with epilepsy should be a planned one. Before planning to conceive, we should decide whether the AED is necessary or not. It involves two decisions. Number one, whether the diagnosis of epilepsy is fairly well established, and number two, whether AED is still required or not. Sometimes it may happen that the diagnosis of epilepsy was an erroneous one. In that case, it would be wise to stop AED before pregnancy, and sometimes the AED might not be necessary at that time. So again, it would be better to stop AED before pregnancy. But if it is decided that AED is necessary and should be continued, patients should be shifted to a drug which is less teratogenic before conception. Some of the AEDs are more teratogenic as compared to other drugs. The least teratogenic, or the drugs with minimal teratogenicity, are levetiracetam and lamotrigine. You can see it in the next diagram that lamotrigine and levetiracetam are the least teratogenic, or they have minimal teratogenicity, followed by carbamazepine, oxcarbazepine, and zonisamide. They have uh, modest teratogenicity, followed by phenytoin, phenobarbital, and topiramate. They have moderate teratogenicity, and followed by valproic acid, which has maximum teratogenicity. So before before conceiving, patient should be shifted to a drug which is less teratogenic. Not only the type of drug, but the dose of drug is also important. Patient should be at a dose which is the least effective dose to prevent seizure, because as we can see in this diagram, as the dose increases, the teratogenicity increases. For example, if we can see for valproate, the teratogenicity is maximum when the dose is more than 1450 milligram per day, and it reduces significantly when the dose is reduced to less than 650 milligram per day. In fact, we can see that the teratogenic potential of valproate less than 650 milligram per day is in fact less than carbamazepine more than 700 milligram per day. So not only the drug, but the dose is also important. Patient should be shifted before conceiving to the least effective dose of a drug which is less teratogenic. And every patient should receive folic acid supplementation. The recommended dose is 1 milligram per day. However, if a patient is using phenytoin, carbamazepine, or if there is history of neural tube defects in previous pregnancy, or if either of the parent is suffering from neural tube defect, then the recommended doses is 4 milligram per day. However, most of the commercial preparations contain 5 milligram per day, and there is no harm in giving 5 milligram per day. Once patient has become pregnant, we should continue folic acid supplementation. AED level should be monitored during pregnancy, because there is fall in AED levels due to an increase in the plasma volume of the patient, due to an increase in renal clearance, and perhaps also hepatic clearance. The AED level should be checked uh, every 4 weekly from the time when the pregnancy is reported, and it should again be checked once 6 weeks postpartum. It should be checked immediately if patient shows increased seizure frequency, or if patient shows signs of toxicity. However, AED level monitoring is not available easily for many of the AEDs. For example, the two drugs which we prefer during pregnancy, levetiracetam and lamotrigine, both of these cannot be tested easily in commercial laboratories. And levetiracetam and lamotrigine both show significant fall during pregnancy. So it would not be a bad idea to slightly increase the dose of levetiracetam or lamotrigine starting from second trimester and reverting back to the normal dose after the pregnancy is over. And should we change AED? Suppose the pregnancy was unplanned and the patient is on a drug which is known to be teratogenic. Should we change it once patient reports to us? The answer is no, because maximum teratogenicity occurs during the first 9 to 10 weeks of pregnancy, and by the time patient reports to antenatal care or reports to a neurology or medicine clinic, it would be 5 to 6 weeks would already have elapsed, and changing AED usually involves an overlap period of 3 to 4 weeks. So we will not achieve anything by changing AED during an established pregnancy just for the purpose of reducing teratogenicity. However, there are two exceptions. Number one, if patient is on multiple AEDs and it is thought that removing one of the drug would not compromise seizure control, then we should try to remove the more teratogenic drug from a polytherapy. And number two, if patient is on valproate, because apart from causing teratogenicity, valproate also causes neurocognitive delay in the fetus, and also causes autism. So and these effects can occur throughout pregnancy. So if patient is on valproate, then we should try to change it to other drug at any time during the pregnancy. And we should also screen the patients for malformations. We should do an ultrasound between 16 to 20 weeks, and if the patient is on carbamazepine or valproate, then alpha fetoprotein level should also be done between 16 to 18 weeks. In the postpartum period, regarding breastfeeding, it should be continued, it should be encouraged regardless of which anti-epileptic drug patient is taking. Now, coming to drug-resistant epilepsy, drug-resistant epilepsy is defined as failure of adequate trials of two tolerated, appropriately chosen and used anti-epileptic drug schedules, whether as monotherapy or as polytherapy or in combination, to achieve seizure freedom. Seizure freedom is defined as a seizure-free interval which is at least 3 times longer than the prior longest seizure interval, or 1 year, whichever is longer. Adequate trial has not been defined properly, but 6 weeks is 6 months is considered adequate. Now, to this diagram shows the enormity of the situation. In 2000, Kwan and Brody published their studies in NEJM. They treated 470 previously untreated patients of epilepsy, and they found that with first monotherapy, around 47% of patients became seizure free, and with second monotherapy, 13% more patients became seizure free, while with third monotherapy, only 1% additional patient became seizure free. While if they used polytherapy instead of third monotherapy, 3% more patients became seizure free. So two things are pretty obvious from this. Number one, that by trying a third monotherapy, we do not achieve much. If patient has been resistant to first monotherapy and second monotherapy, we do not gain much by trying a third monotherapy. And second thing is that 36% of patients did not achieve seizure freedom with even 3 trials. So the enormity of the situation is quite obvious. Now, what to do with these patients? See, if we are making a diagnosis of drug-resistant epilepsy, we should always consider the possibility of epilepsy surgery, because it offers the greatest chances of seizure remission in these patients. And among surgeries, anterior temporal lobe resections for MTLE or for mesial temporal lobe epilepsy gives the best results. And we have proof in the form of randomized controlled trials also. For example, Angel et al. Published their data in JAMA in 2012, and they divided the patients of TLE in two groups. In one group, early surgery was offered; in the other group, medical treatment was continued. And they reported that 11 out of 15 patients in the surgery group and none out of 23 patients in the medical group were seizure free at the end of 2 years, and the results were highly significantly in favor of surgery. Divedi et al. Published their results in 2017 in NEJM for surgery in children, and they divided patients of children of drug resistant epilepsy in surgery versus medical group, and they reported that 77% in the surgery group versus 7% in the medical group were seizure free at the end of 1 year. Other surgical techniques which are used include lesionectomy and multiple subpial resection, but the best results are obtained with anterior temporal lobe resection. Now, this flow chart summarizes the approach to drug-resistant epilepsy. A patient comes with paroxysmal event, and on the basis of diagnostic workup in the form of history, examination, MRI, and EEG, a diagnosis of epilepsy is made. Seizure type and epilepsy syndromes are defined, and patient is started on initial monotherapy. we expect around 50% patients will achieve seizure remission with that. Those patients who fail initial monotherapy are given a second drug therapy, either a monotherapy or a duotherapy. Further 15 to 20% will achieve seizure remission with this. Those patients who do not achieve seizure freedom with this also can be considered for the diagnosis of drug-resistant epilepsy. However, some of these patients will have pseudo-resistant because of wrong diagnosis of epilepsy, because of wrong drug choices. Those who have true drug-resistant epilepsy can be divided into two groups. One group with surgically remediable epilepsy disease, those should be offered surgery, and the other group with surgically remediable epilepsy disease, those patients should be continued on drug trial of duotherapy or triple therapy, and then we have alternative therapies in the form of vagus nerve stimulation, deep brain stimulation, and ketogenic diet, etc. We'll discuss these in a moment. Now, what is the evidence in favor of efficacy of polytherapy? Continuing with the same example of Cohen and Brody, in which 3% patients became seizure free with combination therapy. These patients were followed for 18 years, and they found that 10 years later, 6.4% patients achieved seizure freedom with polytherapy, and after 18 years, 8.4% patients achieved seizure freedom. So with polytherapy, seizure freedom rate increased from 3% to almost 9% with time. So how to combine drugs? How to give polytherapy? Unfortunately, there is no formal guidelines, but there are theoretical recommendations, and these are often referred to as rational polytherapy. We have to consider pharmacokinetics as well as pharmacodynamics before deciding a combination. When we talk about pharmacokinetics, we should remember that if we are using an enzyme inducing AED as one of the drugs of combination, it would increase the metabolism of the partner drug, and so we would need to increase the dose of the partner drug, which can lead to accumulation of toxic metabolites. Also, enzyme inducing AED will increase the clearance of the partner drug, so we will need to give the drug more frequently. That would lead to rapid fluctuation in the level of drugs, which can result in either toxicity or breakthrough seizures. When we talk about pharmacodynamics, we talk about the mechanism of action. We should use drugs with different mechanism of action, because it will lead to supra-additive efficacy with infra-additive adverse effects. Now the question is, how many drugs to combine? Can we combine more than 2 drugs? Can we combine 3 drugs? In fact, most of the RCTs of these newer AEDs were done in patients who were already using 1, 2, or sometimes 3 drugs, resulting in drug regimes of 2, 3, or sometimes 4 drugs. And most of these drugs were found to be significantly better than placebo. And on subgroup analysis, it was the efficacy was not dependent on the number of drugs which the patient was using before. Hence, if patient is not responding to a combination of 2 drugs, it is prudent to use a combination of 3 drugs also. Now, probably it is the right time to discuss the mechanism of action of various drugs. Most of the drugs have sodium channel blockade as their main mechanism of action. These drugs include phenytoin, carbamazepine, oxcarbazepine, eslicarbazepine, lamotrigine, lacosamide, and zonisamide. Levetiracetam and brivaracetam act on the synaptic vesicle protein called SV2A. Benzodiazepines and barbiturates act on the GABA receptors, while perampanel has a new mode of action. It acts on AMPA receptors. Few drugs like valproate, topiramate, they have multiple different mechanisms of action. That is why they are truly broad spectrum drugs. Now, some combination have been found to have synergistic effects and have been found to be very useful in trials. These combinations include valproate and lamotrigine. Although lamotrigine can cause drug rash, and the incidence of drug rash increases if lamotrigine is used along with valproate, but the combination has been found to be pharmacodynamically very synergistic. Then valproate and ethosuximide, lamotrigine and topiramate, lacosamide and levetiracetam, lamotrigine and levetiracetam, valproate and levetiracetam. Then a combination of three drugs, valproate, tribuzam, and seripentol, especially in Dravet syndrome, valproate, lamotrigine, and benzodiazepines. These combinations have been found to be synergistic, have synergistic value. Now, how to choose a second drug in a duotherapy? It's a two-step process. First, we should make a list of AEDs in order of preference by using following criteria. The patient should not have used the drug previously, and if he or she has used the drug previously, it should have been shown to be at least partially effective. It should have a desirable mechanism of action. We should use non-enzyme inducing AEDs, or AEDs which has low risk of interaction with concomitant drugs. It should be effective, or at least should not be deleterious for comorbidities, and should have high therapeutic index or good tolerability profile. Once we have made a list, uh, step two, we should match these drugs with the parent drug uh, as per the following criteria. Like, it should have a different mechanism of action, it should have no or low potential of pharmacokinetic interaction with the parent drug, should have different side effect profile, and should be known to have synergistic interactions in combination. And as per these criteria, we should select the drug. Now, coming to the alternative treatment apart from AEDs and surgery, which are coming up nowadays. First is vagus nerve stimulation. It is considered a safe therapy in adults and pediatric patients with drug-resistant epilepsy who are not candidates for resective surgery. Uh, it has a level 1 evidence for focal epilepsy and level 2 evidence for generalized epilepsy. We don't know the exact mechanism of action, but what we do know is that it influences locus coeruleus and raphe nuclei to modulate cortical excitation through alteration of noradrenergic and serotonergic projections. Uh, it's When we talk about the seizure reduction rate in 1999, a compilation of 5 studies were published, which included around 40 patients. Out of 440 patients, 415 were of partial epilepsy and 25 were of generalized epilepsy. And these patients showed response rate in the range of 36%, 43%, and 42% at the end of 1, 2, and 3 years. And several other studies have shown response rates in the form of 46% and 64% in 4 years and 5 years, and mean seizure reduction rate of 76% at 10 years. What is interesting to note is that the efficacy or the response rates is modest in the beginning, and it improves over time. So the results are not visible immediately, and we have to be patient. The results improve with time. Other important factor is other important point to note is that quality of life parameters show significant improvement regardless of seizure reduction. Even if the patient is not showing improvement in seizure, those patients also show improvement in quality of life parameters. Adverse effects are troublesome in the beginning, but usually settles down, in which they include hoarseness, dysphagia, and coughing because of recurrent laryngeal nerve damage, and discomfort uh, or pain in the oropharynx because of superior laryngeal nerve damage. Now, coming to deep brain stimulation. Deep brain stimulation is used quite often nowadays for Parkinson disease and also for essential tremor, but it is being used for epilepsy also. Uh, the major trial, the Sante trial, was published in 2010 in epilepsy, in which they stimulated the anterior nucleus of thalamus and found in uh, they studied 110 patients and found 68% patients showed good response and 16% became seizure free. And as per the authors, that seizures that responded most drastically or dramatically were focal dyscognitive seizures, and the seizures which could be described as most severe seizures. Complications were not very troublesome. That included asymptomatic hemorrhages in 5% and implant site infections in some patients. It's an evolving field, and other targets are also being tried, like centromedian nucleus of thalamus and hippocampus. The presumed mechanism of action is disruption of unopposed network activity. Other technique which is being tried is direct brain responsive neurostimulation. It's an implantable system which is developed by a neuropace company of USA. In this system, a device is implanted in the skull with sensing electrodes on cerebral cortex, which are triggered by seizure activity, and then a counter stimulation is delivered to seizure onset zone. It is US FDA approved for focal onset drug resistant epilepsy. Recently, Razaki et al. Published real world experience of 8 comprehensive epilepsy centers in volume 150 patients. They showed that median reduction in seizures was 67% at 1 year, 75% at 2 years, and 82% at 3 years. So it appears to be quite promising. Coming to ketogenic diet, it has been around for some time. The classic ketogenic diet consists of 90% lipids with rest made up by carbohydrates and proteins. It is considered gold standard for treatment of metabolic diseases like glucose transporter 1 deficiency syndrome. However, it is quite unpalatable. It is difficult to maintain compliance. So it is not used in adult patients. It is mostly used in children only. However, two modifications of classic ketogenic diet: one modified Atkins diet with 65% fats, 25% proteins, and 10% carbohydrates, and a low glycemic index diet with 60% fat, 30% protein, and 10% carbohydrates with low glycemic index. They are more palatable and more patients usually are more compliant with these diets, and they are being used successfully in both adults and children for refractory epilepsy. Now, an important part to discuss is status epilepticus. The traditional definition of status epilepticus has been 30 minutes of continuous seizure activity or 2 or more seizures without full recovery. And 30 minutes, the time of 30 minutes was chosen because it was shown in studies that after 30 minutes neuronal injury starts to occur. However, it is not practical to wait for 30 minutes before starting treatment, because more the delay in starting treatment, more difficult it becomes to control the seizure. Hence, the current definition is 5 minutes of continuous seizure activity or 2 or more seizures with incomplete recovery of consciousness in between. It is called refractory status epilepticus when clinical or electrographic seizures persist after adequate doses of initial benzodiazepine and an acceptable second line anti-epileptic drug. And it is called super refractory status epilepticus when seizures continue more than 24 hours after the onset of anesthetic therapy. When a patient presents with status epilepticus, our initial aim is to stabilize the patient. We have to check the airway, breathing, circulation, etc. We should check glucose, and we should obtain an IV access and send the blood for testing. We should be able to do these things within 5 minutes. And then we could first give a benzodiazepine. The options available are midazolam, lorazepam, and diazepam. Either we can use intramuscular midazolam, 10 milligram if the weight is more than 40 kg. IV lorazepam in the dose of 0.1 mg per kg per dose. Maximum is 4 milligram per dose. We can repeat lorazepam once if the seizures are not controlled. And IV diazepam in a dose of 0.15 to 0.2 mg per kg per dose, and maximum dose is 10 mg. In a large-scale study in which lorazepam was compared with diazepam, 4 mg lorazepam was compared with 10 mg diazepam, it was found that the seizure control rate was 89% with lorazepam versus 76% with diazepam. So seizure control is better with lorazepam as compared to diazepam. And however, the time of onset and adverse effects were similar, but there were more recurrences in the diazepam group because of redistribution of the drug. In a recent trial called the Rampart trial, which is rapid anticonvulsant medication prior to arrival trial, in which the anticonvulsants were given prior to arrival in the emergency, it compared 10 milligram intramuscular midazolam versus 4 milligram IV lorazepam. It was found that the rate of seizure control were almost similar, but was slightly better in the midazolam group as compared to lorazepam. Now, once we have given benzodiazepines, we have to give a second drug for long-term seizure control. The options include IV fosphenytoin, 20 milligram per kg. Maximum is 1500 milligram. Or we can use IV valproate. These are American Epilepsy Society guidelines, and the doses are given as per that guideline. Although it appears slightly higher, what we use in our emergency setting. IV valproate in the dose of 40 milligram per kg, maximum dose of 300 milligram per dose. IV levetiracetam can also be used, 60 milligram per kg, maximum is 4,500 milligram per dose. We don't often use these high doses, and if none of these are available, then we can use phenobarbital also in a dose of 15 milligram per kg. Now, if we compare these 3 or 4 drugs, which is better, in a meta-analysis of 22 studies which compared AED in the treatment of benzodiazepine resistant status epilepticus, it showed that valproate was effective in 75.7%, phenobarbital was effective in 73.6%, although it causes a significant amount of respiratory depression, so it should not be a drug of first choice. Levetiracetam controls seizures in 68.5%, and phenytoin only in 50%. So valproate and levetiracetam should be drug of choice as per this meta-analysis. And a randomized controlled trial is ongoing with the ESET trial, established status epilepticus treatment trial. It is comparing valproate, levetiracetam, and phenytoin, and probably it could answer this question. And if the seizures are not controlled after benzodiazepine and the second line drug, then it is called refractory status epilepticus, and then we need to give anesthetic doses of thiopentone, midazolam, pentobarbital, or propofol with continuous EEG monitoring. And if seizures are not controlled even after 24 hours of anesthetic doses of these drugs, it is called super refractory status epilepticus, and the treatment of super refractory status epilepticus is not defined. And however, we can use ketamine for that. That's the end of my slides. Thank you.
Thank you, Dr. Rajesh, for comprehensive overview of epilepsy. So before we take some questions from the audience, just a quick, your opinion regarding for physicians and for postgraduates. the basic, waves that we see in EEG diagnosis. So what actually they mean, and how you interpret it.
So the diagnosis of epilepsy is made on the basis of history and the semiology of seizures. EEG, the role of EEG uh, in three things. Number one, to confirm the diagnosis of seizures. Number two, to diagnose the seizure type. And number three, to diagnose the epilepsy syndrome. So I sometimes think that EEG is overrated. EEG is not required in every patient.
Yeah.
So we can make diagnosis of seizures and epilepsy without EEG also.
You mean to say that EEG is not always required in the
It
diagnosis?
is not. That is what I mean to say.
Right.
It is not always required. Suppose a patient comes with seizures, with focal seizures, and the semiology is quite clear of focal seizures. So we can make a diagnosis of focal seizures on the basis of semiology only.
Right.
And if we do an MRI then and find NCC or tuberculoma or a tumor, then there is no need of doing an EEG.
Not asking the question in a different context, that what is the basic indication of doing EEG? That you said that it's not required most of the time. So what is the indication of doing EEG, right, when it is required?
Number one, if we want to confirm diagnosis of seizure, the diagnosis of seizure is not clear from history.
Okay.
Number two, if we want to diagnose the seizure type, whether it's a focal seizure or generalized seizure. Number three, if we want to diagnose the epilepsy syndrome, some epilepsy syndromes have characteristic EEG finding. Suppose we are suspecting juvenile myoclonic epilepsy on the basis of history. We have a young patient between the age of 10 to 20 years with characteristic myoclonic seizures for last 1 to 2 years with a single GTCS, and we want to confirm the diagnosis of juvenile myoclonic epilepsy, then EEG should be done. In that case, MRI would not be required.
Okay. So you mean that EEG would be diagnostic?
Yes. So these are the three indications of doing an EEG.
The one most common that people write, that EEG, this MRI with epilepsy protocol. So what does it mean?
MRI with epilepsy protocol takes diagonal cuts of the hippocampal area with diagonal thin cuts. In some patients with chronic epilepsy, there may be mesial temporal lobe sclerosis. Okay. That is diagnosed with epilepsy protocol MRI. If a patient has come with first seizure or recent onset seizure, then there is no need of doing an epilepsy protocol MRI. It should be done in patients with chronic long-term epilepsy to diagnose mesial temporal lobe sclerosis.
Okay. So one of the very common situation, Dr. Rajesh, comes for a physician, that a patient of idiopathic epilepsy, coming at treatment and they, just follow for 3 months. Sometimes people ask that how long you have to continue. So what is the recent protocol of discontinuing AED or tapering off AED in a patient of idiopathic epilepsy?
In some epilepsy syndromes, if we stop the drug even after 3 years, 4 years, or 5 years, they would most likely recur. For example, in juvenile myoclonic epilepsy, patient needs to be on AED for a long term, probably lifelong. So in those patients, we should not stop AED even after seizure-free interval of 5 years or 10 years also. As we discussed during the class, there are certain risk factors, and if these risk factors are present, they increase the chances of recurrence. And one of the risk factors is epileptiform abnormalities on EEG. So in patients of idiopathic epilepsy, EEG will continue to show epileptiform abnormalities even after a seizure-free interval of 3-4 years. So in those patients, we should not stop or should not try tapering AEDs.
So there are a few questions on chat box. How frequently should drug levels to be checked in non-pregnant patients?
Usually, if a patient is stable and there is no change in the drug schedule, no new drug is being added, then I don't think routine monitoring is required. But if a patient is showing increased seizure frequency, or if patient has come with breakthrough seizures, or if patient is showing signs or symptoms of toxicity, then AED level should be checked. Or if we have added a new drug which is likely to cause interaction with the AED, then it would be wise to check the levels after say 4 weeks.
Okay. So the question is that in a patient is taking AED during for more than 3 months in pregnancy, right, without reporting to physician. So what should be done at that particular time?
As we discussed earlier, we should not stop. We should not change an AED during an established pregnancy just for the sake of reducing the chances of teratogenicity. And we also discussed there are two exceptions to this. If patient is on multiple AEDs, then we can try to remove one of the more teratogenic AEDs from the polytherapy. And if patient is on valproate, then we should try to change valproate irrespective of the time of pregnancy.
Okay. So the question is that in a status epilepticus, if seizure is not controlled after repeating second line agent, is there any role of giving another second line agent before considering anesthesia?
See, there have not been any randomized controlled trial regarding this. So various associations have given their guidelines, and some of them say that if the first second line AED fails, then we may try a second line AED. For example, after a benzodiazepine, if we have used fosphenytoin and if it fails, then we can try levetiracetam or valproate before going to anesthetic agents. But what we have discussed here, the guidelines by the American Epilepsy Association, they say that when the second line AED fails, then we should straight away go to anesthetic agents.
Okay. Another question is when should be considered to switch to second AED in unprovoked seizures not responding to first AED?
When should it be considered to switch? If the first AED fails, then we should switch to second AED. See,
so when we say that it's failed,
when we are starting a drug, we should start at a low dose and gradually build it up till the time either the seizures are controlled or patient starts showing side effects of the drug. So if the patient has started showing side effects and seizures have not been controlled till then we should consider that the drug has failed and switch to a second drug. We can switch to a second monotherapy, or we can add a second drug to make it a polytherapy.
Right. It is actually when we say that is a full therapeutic dose of first AED, and then then to start the second AED. Not that you are not given the full therapeutic dose and then you start AED. Then I think it won't be right choice.
Yes.
Just adding to this, I just wanted to know what is the role of drug levels in such patients to ensure that compliance is there, or we have achieved the therapeutic drug levels. Do we regularly do drug levels in such patients, or we only do it in selective patients?
Sir, if we are suspecting that the patient is non-compliant, then probably we can check by doing a drug level at that time.
So non-compliance would reflect by episode of seizure only, no?
Yes. If a patient has come with seizure, then yes, right, we can do a drug level.
If the patient taking drugs, that there wouldn't be any throwback seizures in that particular patient.
Right.
So what was traditional teaching was that if once the patient has responded to a particular drug and if sort of a seizure free for some time, then if he gets a breakthrough seizure, most likely it is his non-compliance to the drug, to the medications is important rather than actually resistance to a particular drug. So what is your take on that as of today?
It is the same right now also. If a patient has been seizure free on a particular dose and particular drug and he comes with a breakthrough seizure, then we should suspect non-compliance and we should first check drug level before going into a second drug.
So, Dr. Rajesh, are you doing your clinical practice drug labels that sir has asked?
Drug labels are not available for all the antiepileptic drugs.
That's
They're
what we have
available for they're available for mostly the older generation drugs like valproate, carbamazepine, and phenytoin. And nowadays, more patients are on newer generation AEDs like levetiracetam and lamotrigine and other drugs. For them, drug labels are not available, unfortunately.
Right. So there's another question that if we have to start an anti-epileptic drug like valproate or phenytoin on OPD basis, should we always give a loading dose before starting?
For phenytoin, there has been a recommendation that we can give oral loading of phenytoin. We can give 20 milligram per kg body weight of phenytoin, like in a 50 kg adult, we can give 1000 milligram of phenytoin in 3 divided doses on day 1.
Okay.
And then from day 2, we can resume the normal dosing of phenytoin. But for valproate, there has not been any recommendation like this.
And levetiracetam?
Levetiracetam, we can start with the full dose right from day 1.
Right from day 1. Okay.
But if we start with full dose with valproate, it usually causes excessive sedation, and patients find it difficult to tolerate.
Right. So in valproate, we have to start gradually. We have to build up the dose.
Yes.
Okay. So the question is, patient taking valproate or and becomes pregnant. So should we try to reduce the dose, or what we should do? Because you said that the higher the dose would cause this statin effect as compared to lower doses.
Ideally, the pregnancy should be a planned one, and we should try to shift the patient to a lesser teratogenic drug with lesser dosage. But if the patient has become pregnant and she was taking valproate, then it would be wise to shift the patient from valproate to a lesser teratogenic drug, as we discussed earlier, because valproate, apart from causing teratogenicity, also causes autism and cognitive dysfunction in newborn, and which is irrespective of the pregnancy trimester. So if patient is taking valproate during the 2nd trimester and 3rd trimester, then also it is harmful, unlike other AEDs.
Okay. The role of folic acid in non-pregnant patients with valproate?
I don't think so. There is no role of folic acid in non-pregnant patients, but in every patient of childbearing age group, we should use them, because sometimes patients become pregnant without planning.
Right. And the role of midazolam spray, nasal spray in epilepsy?
In patients who often land up in status epilepticus, it is probably a very good choice to terminate seizures at home, because it is quite safe and it is also quite effective. But for patients who develop single seizures only, there is no role of midazolam spray.